Well, I want to welcome everyone to our Learn with the Leaders with Dr. Raquel Watkins. The topic is atopic dermatitis. I'm going to review a little bit about Dr. Watkins. She is in pediatrics and adult allergist, board certified in allergy and immunology. Her offices are in Jacksonville and in Orange Park. She treats allergies, asthma, and allergic skin disorders. Her training was at the University of Miami undergrad and the University of Maryland School of Medicine. Also at Wake Forest University, internal medicine residency, a master's in clinical epidemiology, and allergy and immunology fellowship. At this time, I'd like to turn it over to Dr. Watkins. Thank you for speaking with us tonight, Dr. Watkins.
Hello, thank you, Sydney, for introducing me. It's really a pleasure to be here, and I'm excited to spend the next 20 minutes or so talking about atopic dermatitis. I work with a great clinical team, and I will also introduce you towards the end to our research team. Today, the objective, just the overview, is that I'm going to spend a few minutes talking about, giving an overview on atopic dermatitis, and then I'll talk briefly about the causes, the current treatments, and also future options. So why is atopic dermatitis important? Well, according to the National Eczema Organization, about 1 in 10 Americans will develop atopic dermatitis at some point during their lifetime, and it's often more common in childhood. So this rounds out to about 9.6 million American children who are affected with atopic dermatitis. And about 1/3 of the children have moderate to severe disease. About 16 to 17 million adults will have atopic dermatitis at some point during their lifetime, and many of them will start to develop symptoms as young as age 2, and about 40% of them will develop more severe disease. So there are a lot of people that are affected, and the burden of atopic dermatitis is great because one of the hallmarks of atopic dermatitis is itching. And so if you can imagine, and many of you can who are tuned in, if you're itching and scratching all night, you won't sleep very well. And so one of the main problems that we see in atopic dermatitis are sleep disorders. And we all know that if you're not sleeping well, you're not going to perform as well in school or at work. Sleep disorders are also associated with psychiatric problems, memory loss, and even heart problems, cardiovascular disease. So the burden is great, making it really important for us to approach this problem seriously and to try to help patients who suffer to reduce their burden. So what do we see? How would a patient present if they had atopic dermatitis? Well, as I mentioned earlier, one of the hallmarks is itching. And so there's a lot of itching, there's a lot of rubbing and scratching, and many patients have external triggers, which I will review in just a minute. There's also a typical distribution. So as a physician, when I see a patient with a rash and I'm thinking that it's atopic dermatitis, I want to be sure that I am excluding other more serious conditions, for example. So I'm going to be looking to make sure that the rash and the itch is in the typical distribution that you would expect in atopic dermatitis. And I'll review that with you in a minute because it's going to be a little different in children versus adults. Atopic dermatitis is a chronic problem. It comes and goes, it's relapsing, and sometimes it can be very hard to control. It's associated with allergies. So runny, stuffy nose kind of allergies, itchy eye kind of allergies. It's also associated with asthma, food allergies, and an allergic esophagus. We call it eosinophilic esophagitis. So here's a distribution that we see in children. So in children, they're going to have the itchy rash in the creases on their arms, and they'll also have an itchy rash behind their knees and sometimes on their knees. They'll sometimes also have a rash under the neck area, their forehead, the back of their head, and sometimes even around their ears. It's a little different in adults because remember, adults have had this problem for a long time. And so often it's hard sometimes to differentiate. Is this atopic dermatitis? Because they're going to have some areas that are thickened on the skin. We call it lichenification. So the skin has thickened somewhat, but traditionally you'll still expect to see a rash in the creases of the arms, where you bend your elbow. You'll see it behind the knees. Many adults will have hand and foot dermatitis or rash. Many adults who have atopic dermatitis because irritants are beginning to play a role. And oftentimes they'll have it on the face as well, around the eyes, around the mouth, under the neck, and even behind the ears. It can also affect private areas, the nipples, for example, as well. So what causes atopic dermatitis? I think it's really important to think about the cause, because if you can think about the causes, then you can better understand why your doctor might recommend a certain treatment regimen or why it's important to follow through with the treatment regimen. So there are three main problems with atopic dermatitis. The first is that the skin barrier is not working well at all. The second problem is that the immune system has become overactive. So it is causing a lot more inflammation, which is unnecessary. And then the third problem is that the way that the skin responds to bacteria is affected. So we call that an alteration in the microbiome. And I'll explain all of this in a little bit more detail. It'll make a lot more sense when you look at this slide. So think about it. Your skin is the largest organ, and its job is to protect you, right? It's to protect you from things on the outside entering your skin. It helps to keep your temperature right. It helps to hold those organs in. So if you can think about the layers of the skin, if you look on the right side of this slide, if you can think of the layers of the skin as a brick wall, and on this brick wall, to hold the bricks together, to hold the cells together, you have mortar, right? Or an adhesive. So in atopic dermatitis, the adhesive, the mortar, is destroyed. It doesn't work. And so the waterproofing of the skin, one of the main functions, is destroyed. In addition, the bricks are cracked and brittle. And so you end up with very dry, irritated skin. So transitioning over to the left side of this slide, let's look at this cartoon to see how, we can make sense of it all. So you're now dealing with a skin barrier that has lost its mortar, its adhesion, and all the bricks or the cells are kind of brittle and just not working right. And then we have irritants on the surface of the skin, because as you go through life, you're going to want to use a lotion, aftershave, deodorant. All of these things can be irritants in some people. In America, we use about 160 chemicals on our skin every day. So it sounds like a lot, right? But this occurs even if you're not using a lot of makeup or products. It's just general hygiene, washing your face, washing your hair, using deodorant. These are all chemicals. And these chemicals over time can be very irritating to patients who have atopic dermatitis. As I mentioned, the waterproofing is destroyed. The mortar doesn't work. It's not holding things together. So these irritants seep into the skin. It activates the immune system, and that leads to a lot of inflammation on the surface of the skin. Allergens also play a role in atopic dermatitis. So food allergens, for example, or pollen, pet protein is another example. Those things interface with our skin, and although they don't cause atopic dermatitis, they take advantage of the defect in the skin barrier. They seep through, activate the immune system, and that leads to a lot of inflammation on the surface of the skin. Mm-hmm. Last but not least is bacterial infections and viral infections. So,
oh no, I'm fine. I just wanted to make sure that she's not having no issues.
All of us have, our skin interfaces with bacteria on a daily basis. Staph aureus, however, is unique because in atopic dermatitis, patients, Staph aureus seems to cling to their skin. We call it colonization. And when Staph aureus enters through this weakened barrier, it has a unique ability to activate the immune system very quickly. So it's a super antigen. And again, that will lead to a lot of inflammation on the surface of the skin. So having an impaired barrier is one of the main problems with atopic dermatitis. And one of our goals is always to try to repair the skin barrier. And I'll review that with you in just a quick minute. This is just to sum up what's happening with the epidermal barrier dysfunction. You have a lot of water loss. That mortar that I was given an example with the brick wall, the medical term for that is filaggrin. It's a structural protein that doesn't work anymore, that leads to problems with the skin barrier. And our skin has lipid components and proteases and a lot of other things that work together to help to protect us. And all of that is a little dysfunctional in atopic dermatitis. I show you this slide to just get you an idea of the scope of the different portions of the immune system that are hyperactive in atopic dermatitis. So when we think of treatment options, the scientists, doctors are going to try to give you medicines that are going to block some of these cells to see if we can tame the immune system slightly so that it's not so overactive, and in the end, you don't see as much itching and irritation on your skin. This makes sense when you, for example, if your doctor prescribes a drug for you, when you pull out the information, you're reading the fine print, it might say anti-IL-4 or anti-IL-13. So it's good to have an idea. I don't expect you to, understand all the science behind it, but it's good to have an idea of the scope of the immune system so you can better appreciate the medications that you're given. And I already talked a little bit about this, the microbiome. 90% of patients with atopic dermatitis are colonized with Staph aureus compared to 5% of unaffected. It's a super antigen. It ignites the immune system, leading to downstream inflammation. And so often we will recommend if I see signs of an infection brewing on the skin in someone who has atopic dermatitis, I'm quick to try to treat that so that we can dial down the Staph aureus so that the skin can heal. So in summary, current treatments are going to address basic skincare because the barrier is impaired. Treatment's also going to be targeted at the immune system, and those medications can either be topical that you rub on the skin or given by mouth, or they can be injectables. So let's talk a little bit about that. First is the epidermal barrier repair. So there are 3 steps to try to repair the skin barrier if you have atopic dermatitis. The first is bathing. So remember, we talked earlier about the waterproofing being impaired. You're losing water when you have atopic dermatitis. The skin is getting drier. So you do not want to take long showers in very hot water. You want to use lukewarm or cool water to bathe. And you don't want to spend a long time in the shower either. All right. The second step is to make sure that you're using lower pH soaps. So let's talk a little bit about pH. So pH is just the acid-base status of anything, really. And if you could think of a scale with 0 being on one end of the scale. So 0 would be something like battery acid, okay? It's very acidic. It's going to burn your skin, so you don't want to touch it. And then on the far end of the scale would be, say, the number 14. And that would be something more basic or alkaline. And that's something like bleach or lye. Again, you don't want to really get that on your skin, but that gives you the framework of the pH scale. And then right in the middle is water. Water is neutral. So your skin, everybody's skin, likes to be a little bit on the acidic side of water. So normal healthy skin wants to live at a pH of about 4.5 to 6.5, right? So we have to choose soaps that are on the lower pH side, on the acidic side of water. We don't want to choose soaps that are too alkaline on the bleach side of water, because those are going to dry out the skin further and they're going to make the skin not as able to do its job. The reason the skin likes a more acidic pH or acidic side of water is that that's how it helps to fight off bacteria and keep you protected and be a good barrier for you. The third step in repairing the epidermal barrier is moisturization. So a typical day when you're bathing for an atopic dermatitis patient would be, you bathe in cool or lukewarm water, and then you use a lower pH soap, right? And then if your doctor has prescribed any prescription ointments for you, you're going to apply that after you dry off. And then on top of that, you're going to apply moisturization. Examples of lower pH soaps would be Vanicream, CeraVe, Cetaphil. They're all available over the counter. They're not, special order or prescription either. And good moisturizers would be, say, Vanicream, CeraVe, Eucerin, anything that's, a little bit thicker. Lotions aren't as good, but can work depending on your preference. But I would recommend typically to try a lotion. So these are the 3 steps that I think that everyone with atopic dermatitis should be going through on a daily basis, whether you have mild disease, moderate disease, or severe disease. And it works. Here's a testimonial from a teenager. And, because teenagers are harder. Sometimes they want to do it their way. And so this teenager wrote, I think that for me, the advice I got from the doctor that helped the most was to just start taking care of my skin. At first, I didn't want to do it, but now it's just my routine. I only use the right pH soap and I moisturize. I know I still have eczema, but I don't itch and my skin is not always irritated. I just stick to my routine. That made me really happy to see. And here's a before and after picture. You can see improvement with simple skincare. It's really important. So now let's transition to medications. So if, as I mentioned earlier, if one of the main problems besides the impaired barrier is that the immune system is dysregulated, then a lot of what we recommend is going to be targeted at the immune system. So I think of treatment for atopic dermatitis as 2017 being a pivotal year, because prior to 2017, we did not have a lot of medications in our toolbox. As you can see on the 2016 slide here, we had topical steroids, right, that we would recommend to rub on your skin. And we had prednisone that you take by mouth. We also would recommend antihistamines for that itching that would just keep you up all night. We had medications like Elidil, Protopic, which we still use. And then we would treat the Staph aureus or the infection with mupirocin topical to apply, or we would recommend antibiotics to be taken by mouth. And then in 2017, we had 2 new drugs that came to the market. The first was a topical ointment, and it was not a steroid ointment. So that was kind of exciting for many patients who had been on chronic steroids. And that ultimately got approved for children and adults. And it's really good for, I would say, milder disease, because I think if you have to put an ointment all over your cream and you have severe, it's covering a lot of your body, that's just a lot harder, right? Anyway, the other drug that came out in 2017 was an injectable. It's an anti-IL-4. If you think back to the earlier slide, I showed you all of the immune areas, players that we focus on targeting. This medication is given as an injection, and it blocks the IL-4 receptor. And so it's also approved now for children and adults, and it can treat moderate to severe atopic dermatitis. So fast forward, 4 years go by, nothing new, nothing much news going on in terms of treatment options. And then in the fall of 2021, and then now this year, 2022, we now have 4 new medicines on the market to treat atopic dermatitis. 3 of them are targeting a kinase inhibitor, so another area of the immune system. One of them is a cream, and that's approved for children, the Opzelura. And then 2 of them are pills that you take. One's Rinvoq and Cibingo. And these are usually, these have been approved when you're failing other therapy. And then fourth on the list is a new injectable. Again, it's an anti-IL-13 drug, and it's called Adbry, and that's available in adults only and for moderate to severe atopic dermatitis. So where do we go from here? I think if I do this talk again in the future, I'll probably have a star on 2017 and a star on 2022, because I think 2022 will be a pivotal year, because we have all these new drugs and we have to learn how to use them. And I think ultimately will help patients who are struggling with atopic dermatitis to get better control and to be able to sleep better and just live a better life that, you know, is not full of itching. And some people too with atopic dermatitis have a lot of cosmetic concerns because it's on their face, on their hands, and it just impairs their ability to function normally. So in 2022, we're going to be using a lot of new drugs, and I think there's a lot more work to be done in the research area, because I liken how we're progressing here with atopic dermatitis to how we have progressed with asthma. So for decades, we treated everybody with asthma very similarly. We didn't know any better, right? And then over the past several years, we realized through research that not everyone with asthma wears the same size shoes. They're not the same phenotype. Different cells trigger asthma flares in different patients. And so I think that we're learning something very similar with atopic dermatitis. So I believe that there's a lot of work to be done in the research area to look at different areas of our immune system to see if targeting those areas can lead to safe therapy and good benefit for patients. So here at Encore Borland Groover Clinical Research in 2022, there's a new atopic dermatitis study that I wanted to share with you, and I'll have Cindy chime in a minute just to kind of answer any questions or to just say a few things about the study as well. But this study is targeted at adults who have moderate to severe atopic dermatitis for over 3 years, so 3 years or more, and who have never been on another injectable, such as, remember in 2017, I mentioned that new injectable Dupixent came out, dupilumab. So you cannot have been on that to be in this study. I think research is exciting. There are many reasons why people would want to participate in a clinical trial. First of all, it's simply to find relief for their symptoms. Many patients, many people want to help to advance medical science. You know, where would we be? 2017 would not have resulted in new medicines, or 2022 if patients hadn't agreed to say, okay, I'd like to help to advance medical science. And by doing that, they're helping the over 60 million adults and over almost 10 million children who are struggling so that new medications can come to the market. I think other reasons to participate would be to gain access to new treatments that are not yet available on the market, and to help to make a difference for future generations, and ultimately to feel valued and cared for, and to become part of a bigger cause and to become part of our community. You can learn more about this clinical study by going to EBGCR.com. We have an excellent research team, strong, and they can help. So you can call or email, and you can learn more about the study. This is the phone number here. It's been on the top of our slides as well, 680-0871, or you can email at research@borlandgroover.com to learn more about our atopic dermatitis study and other studies as well. If you have questions about current treatments, we can help you in the clinic as well, and you can contact us at our number that's listed on the screen there. Email us at the allergy office at Borland Groover Clinic or bgclinic.com, or go to our website. So at this time, I'd like to just allow Cindy to say a few words about Encore Borland Groover, clinical research, and I'll turn things over to her. And then if you have any questions for me, clinical questions, I'll be happy. I'm going to stay online here, so you can definitely send me those as well through the chat.
Well, thank you so much, Dr. Watkins. And this is an exciting area. And I think everybody has some type of skin issue. So I'm glad that you're available. And thank you for doing this talk. Participating in a clinical trial, does have all the benefits that were listed. And there is no cost for participation. You'll actually receive a stipend for time and travel if from the research grant, if it's something that you end up qualifying and participating in the study. And at this point, you know how to reach me at the research office and then Dr. Watkins at her office. And I'd like to see if there's any other questions, and then we can conclude for the evening. I think if you have questions, you can type it in the chat. Okay. I don't see any questions at this time. So please feel free to reach out to Dr. Watkins, her practice, or to the research clinic if you think that's something you might want to get more information. Dr. Watkins is the principal investigator for the study, so you will be seeing her as the physician overseeing the trial. And with that, I'd like to conclude. Any other comments or questions?
No, thank you.
All right. Thank you so much. Everybody have a good evening.
Thanks.